Hello, everyone. Welcome. Thanks for attending our Friday noon seminar. Today, we have the great pleasure of welcoming Dr. Louis Gagnon. Louis completed his training in engineering physics at École Polytechnique de Montréal in particle physics, and also spent some time at the Triumph Accelerator in Vancouver, where I was actually a student along with Louis and met him at that time. He subsequently earned master's degrees in biomedical engineering at École Polytechnique and electrical engineering at MIT. He then did his PhD at the Harvard-MIT Division of Health Sciences and Technology, came back to Quebec, to the University of Laval to do his MD and a residency in diagnostic radiology before pursuing a subspecialty in MRI and artificial intelligence at the University of California, San Diego. Not a lazy guy. He has been a radiologist at the CHU de Quebec, a professor in the Department of Radiology at Université Laval, and a principal investigator at the CERVO Brain Research Center since July 2023. His research focuses on neuroimaging, particularly on modeling and physical principles, as well as artificial intelligence in neuroradiology. And I had mentioned that I had first met Louis when we were Triumph students. It's actually the last time I've spoken with him. 20 years ago, I invited him to give a talk, and I actually have a pic. Did I save it? Can we see this? So this is a picture of the summer students at the Triumph Institute in Vancouver. They hire a lot of summer students. Louis is prominently displayed front and center. You can tell he's the alpha of the group. I'm somewhere on here. Maybe this guy over here. Anyway, it was a good time. But Louis has gone off to do greater and better things, and he's going to talk to us about that today. So, Louis, I'll let you take over the screen sharing again. If I stop sharing myself. And I'll let you put your full screen on.
Is it still on? I think I'm still on, so...
So you're sharing your whole desktop right now.
Okay. And now you see full screen?
Now we see full screen.
All right. So thank you very much, Pete, for the introduction. And thank you so much for the organizer for inviting me. Pretty excited to talk about the schoolwork regarding advanced diffusion MRI and also deep learning with application in neuro-oncology. The outline of the talk, I'm going to talk about glioblastoma, which is the core of my research program at Laval University. I'm going to introduce some diffusion MRI technique, and we're going to combine that with deep learning, which is kind of a hot topic right now in neuroradiology for application in glioblastoma imaging. Then I'm going to finish by talking about some ongoing work in my lab and some future work that I would like to pursue. So glioblastoma is a terrible disease. It's the most common primary brain tumor in adults. It's a high-grade tumor, WHO grade 4, which is the highest grade, with very, very poor prognosis. The overall survival is 15 months, and the 5-year survival is only 10%. So just to give you an example, in Canada, each year, more than 3,000 people are diagnosed with this disease, and 2,500 will die of this disease each year only in Canada. So this is what a glioblastoma looks like. This is T1 images at the top, pre and post contrast. You see that there is this enhancing periphery with this necrotic core, and the tumor is surrounded by this flare or T2 signal hyperintensity, which is a mixture of edema, but also infiltrative disease, so non-enhancing infiltrative disease. And actually, one of the challenge will be to actually separate infiltrative disease from edema in these flare and T2 images. So treatment for glioblastoma is the resection of the enhancing portion of the tumor. We'll talk a bit more about that later. Followed by radiotherapy and chemotherapy. And in some very specific cases, but very limited cases, we're going to use some anti-angiogenic agents, such as bevacizumab. So here's again the glioblastoma. with his peripheral enhancement, necrotic core, and at the periphery of the enhancement, you have this band of flare signal like hyperintensity, which is a mixture of infiltrative disease and edema. But it's very hard with conventional sequences to delineate in this peripheral hypersignal intensity region where's the edema and where's the actual infiltrative disease. So this is one of the reasons why surgeons will only resect the enhancing portion of the tumor, because it's easy to delineate. They know exactly where to cut. And also because it's high grade, so you don't have choice. It won't respond to chemotherapy and radiotherapy. So everything that you're sure and it's high grade, you remove it. But because it's in the brain, the more you remove, the more neurological deficit you impose to the patient. So it's an area in radiology where the precision of the delineation is very important. And if you imagine that they would remove all this peripheral component is often much larger than the tumor itself. So this would create a very large neurological deficit for the patient. And you're not even sure that what you're removing is just edema or infiltrative disease. So for that reason, because of the difficulty of delineating the infiltrative component, they won't resect this part. And also because it's not enhancing, we believe it's lower grade tumor. So the rationale is that in order to get enhancement, you need the blood-brain barrier to be disrupted, and this is caused by high-grade tumor. If the infiltrative tumor is not enhancing, the blood-brain barrier is not disrupted, and we believe it's lower grade. And because it's lower grade, we tend to believe that it's going to respond to chemotherapy and radiotherapy, so we don't really need to remove this part, especially if we don't know exactly where to cut. But the reality is very different, right? Because the overall survival is 15 months, so definitively we need to do better. And some recent studies, so recent, I mean like 2022, 2023, this meta-analysis review showed that if you start removing part of this peripheral component of the tumor, naively by just extending the resection margin by 20%, 50%, 70%, you see a significant increase in survival. And significant in this case can be like 3 months. 3 months over 15 months, it's 20%. It's significant. And this technique is called supramarginal resection. But it's not widely used by neurosurgeons because surgeons are not confident when they remove this part of the tumor like blindly without knowing what exactly they're removing. It's really also difficult to justify to a patient something like, now you're paralyzed because I removed extra component of your brain. I wasn't sure if it was edema or tumor, but I thought I would remove it, and now you're paralyzed of one harm. So it's difficult to justify to the patient, and it's not evidence-based precisely. So that's why they're not pursuing this supramarginal resection. But as you see here, if we could give confidence to neurosurgeons to practice supramarginal resection by, delineating with more accuracy the infiltrative portion of the tumor and separate that from edema in preoperative MRI, that would be game changer, and it would probably increase survival in glioblastoma patients. So this is the first challenge of glioblastoma imaging, delineating infiltrative disease in preoperative MRI. Another big challenge is on the postoperative images. And the challenge is to distinguish recurring disease from post-treatment changes. The reason is that both of these entities will occur at the periphery of a surgical cavity, and they will both enhance. And with conventional MR sequences, it's very hard to distinguish between the two. So here, for example, you see the surgical cavity here, another surgical cavity here, and you see this nodular enhancing component here that is appearing on one of the follow-up. And it's very hard to say, is it recurring disease or is it like post-treatment changes such as radiation necrosis? Both things will look exactly the same. So more than often we just say, okay, we're going to follow up in 1 month and see how it goes. And in the next scan, you see that it disappeared completely. So it was like post-treatment changes, in fact, radiation necrosis. But if it stays there and it continues to grow, then it's most likely recurring disease. But we've lost 1 month by waiting to see on the follow-up. So it creates delays in patient treatment. And of course, you don't want to go back to surgery if you're not sure that this is recurring disease. So you want to minimize unnecessary intervention. And therefore, finding a better way of distinguishing recurring disease from post-treatment changes would be really game changer in glioblastoma patients. Finally, another challenge is to predict survival in these patients, because not every patient wants to receive surgery. And identifying patient that would respond to treatment would allow to adapt treatment, at the individual patient level, and this would allow for improvement in the allocation of resources in our health system. It's a very difficult task because the current biomarkers are only available in the post-operative state. So you cannot use this marker before the surgery. You have to go to surgery, and after that, use this marker to say, is the patient expected to live longer or not? One of these markers is the MGMT status. It's a genetic marker. So once you have a tissue sample from the surgery, you can do some amplification of the DNA. And if the sample is methylated, we say it's MGMT positive. And if it's negative, we say it's MGMT negative. And the other marker is the volume of residual enhancing tumor on the postoperative MRI is also a good predictor of survival. But as I said, both of these markers are only available after the surgery. But for the neurosurgeon, the important decision is, before the surgery. Are we going to surgery or not? So if we could provide them with biomarkers that are available at the time of, the diagnostic, like at the first appointment, that would help the patient to decide if they want a surgery or not. And a lot of these, a lot of work has been done in the past 10 years with the advent of AI. But most of them relies on radiomics. And radiomics is just that you use some volumetric data and you compute a lot of mathematical transformation to create a bunch of numbers in a mathematical space. It could be like wavelet transform coefficient. It can be like intensity normalization, variance analysis, harmonics, etc. And the thing is that all these features are not interpretable by humans. So it creates this kind of black box where the decision will be split, positive, negative, or like long survival, short survival. But the black box, you're gonna go back and understand why you are a long survivor or why you're a short survivor. And it's very difficult for clinicians to use these arguments with the patient and say the machine is telling you that you're going to be a long survivor, but we don't understand why. So we need something more interpretable by clinician. And another difficulty of radiomics is that if you train your radiomics model on a specific data set, and this data set comes from a single institution, then it's very hard to generalize to other institutions because other institutions will have different parameters, different imaging platforms, and because there is overfitting in your trained model, it's going to create a decrease in performance when you're going to apply it to another data set. So nowadays they tend to use larger data sets from multiple institutions and other methods such as foundation models and stuff like that. So it's improving, but radiomics is still difficult to apply in a clinical workflow. So one of the challenge is actually to define a new survival predictor, but from a more interpretable biomarker. And we'll do that by producing cellular tumor maps from advanced MRI and AI. So here I just summarized the major challenges, which is segmenting infiltrated disease in pre-op, on post-op distinguishes recurring GBM from post-treatment changes, and try to predict survival from data analysis in a preoperative framework. So in order to achieve these tasks, we're going to use, or we used, I developed this project during my fellowship at UCSD. We used a powerful multishell diffusion technique, which is called restricted spectrum imaging, RSI. And multishell means that you will acquire diffusion measurement with different diffusion gradient strength on the scanner that we call B-values. And we model the signal using this circle harmonic decomposition, and we assign each of these compartments, each of these harmonics to different tumor compartment. For example, the short scale spherically restricted compartment is associated with tumor nucleus or tumor cellularity, while the hindered compartment is associated with edema. So you can imagine that if you can distinguish these two compartments in your signal, you can then isolate cellularity and get rid of edema, which is what RSI will do. And experimentally, you just acquire multiple diffusion images at different diffusion gradient strength and different orientation. And so at the end, you get like 35 different measurements. And then you use a linear model to actually compute the weight of all these compartments in the signal, and you can then isolate the compartment that you want. So I'm going to show you some example of what it looks like. Here you have an enhancing nodule at the periphery of a surgical cavity with some flare signal hyperintensity. And on the RSI, you see that the nodule is very bright, which correspond to high perfusion on the CBV map, cerebral blood volume map, meaning that it's high-grade tumor, so this is a recurring disease. But you see that the flare signal hyperintensity is not bright on RSI because here it's mostly edema. There's no infiltrative disease here. Another example, here you have this large enhancing mass with peripheral flare signal, but you see that the flare signal is not as bright as here. It's kind of intermediate signal with mass effect, and this is very worrisome for infiltrative disease. And in fact, when you look at the RSI cellularity map, you see that bright signal in this flare intermediate signal here, and also on the enhancing component, meaning that both the enhancing disease and the infiltrative disease is highly cellular. But you see that the periventricular neuropathy here, which is not highly cellular, doesn't appear bright on RSI. So actually, RSI can distinguish infiltrative disease from edema on imaging. Here's an example of the application of RSI in postoperative MRI. Here you have the first initial MRI, and you see that following the initiation of immunotherapy, which can create pseudoprogression, you see that this thick enhancement appears, a couple of weeks after the initiation of immunotherapy. But if you look at the RSI map, although it's enhancing, it's not cellular, and on the follow-up, it's going to disappear. So RSI can actually, even if it's enhancing, if it's not bright, it can distinguish recurring disease from post-treatment changes. Here's the example I showed you before, where this enhancing nodule was actually recurring disease. And I'm going to show you, again, the example I showed you before, like surgical cavity, with a nodule, enhancing nodule appearing at the periphery of the surgical cavity, which resolved like on the follow-up. So it was radiation necrosis. And if you look on the RSI here, you see that it's not bright. So we could tell from the beginning that this was actually radiation necrosis. Another example that RSI can distinguish recurrent disease from post-treatment changes. Now, deep learning. So deep learning is a hot word these days. It's been a hot word in neuro-oncology and neuroradiology since the past eight years at least. And the reason for that, it allows for quantitative analysis such as volumetry, normalized intensity, very accurate, fast, and reproducible. And also you can see stuff that the human eye cannot see. For example, very small changes between different time points, texture and variance analysis, which we cannot see with the naked eyes, and three-dimensional, like subtle, complex three-dimensional deformities. You can all compute that with AI, which by only looking with human eye, you cannot really see. And the method is fast and reproducible, and that's why AI is used more and more in neuro-oncology. So in my project in 22-23 at UCSD, I wanted to actually use a combination of these two techniques. So use the power of AI segmentation and the power of RSI to actually map cellular tumor and to segment automatically the cellular tumor in post-operative MRI and use this volume of segmented cellular tumor to actually detect recurring disease and to predict survival in glioblastoma patient. So here's an example of input and output of the AI model. You have conventional MRI sequences, T1 post-contrast flare, traditional apparent diffusion coefficient here for comparison, and you have like RSI cellularity, and you also have like perfusion map. This is the ground truth segmentation that was done by one neuroradiologist, one fellow, me in occurrence, and all third neuroradiologists double-checked all the negative cases. And this is the output of the model. Once you train the model, this is the output. In red, you have the enhancing portion of the cellular tumor, and in green, you have the infiltrative or non-enhancing portion of the cellular tumor. And so we trained this model on a data set at UCSD consisting of 178 patients, 243 time points. We did 5-fold cross-validation in order to get the entire data for training, but to minimize data leakage. And we had an external data set to actually test the procedure because it's important, as I told you before, more than often, when you train a model on a specific institution, when you use it on an external institution, you're going to have a decreased power, and it's useful to have a data set, retain, not part of the training, to test this decrease in performance, and it gives you a sense of how much you can apply this model to the outside data. So here is the segmentation performance in terms of DICE score. So DICE score is a metric between 0 and 1. 0 is that there's no overlap between the ground truth and the segmented tumor. And 1 is perfect match, perfect volumetric match between the ground truth and the segmented tumor by the AI algorithm. So we got DICE score of 0.77, a little bit higher, 0.90 for the enhancing portion, but we see why. It's because it's easy to delineate the enhancing tumor compared to non-enhancing infiltrative disease. The DICE score for infiltrative disease was 0.52. Nicely, we got similar DICE score for the external data set from University of Wisconsin, so we were quite happy about that. One thing I want to mention is that once you have this data set, this ground truth label, you can train a model using all your inputs, including RSI. But because RSI is not widely available in other institutions for many reasons, it's useful to retrain your model, but removing RSI from the inputs and see how much you decrease the performance of your segmentation. And for the enhancing cellular tumor, you keep very good DICE score because you don't really need RSI to segment enhancing cellular tumor. But for the non-enhancing tumor, you see that the DICE score will decrease drastically, like almost by 50%. You go from 0.5 to 0.25. If, on the other hand, you substitute RSI with conventional diffusion sequence, such as the apparent diffusion coefficient, then you're in between 0.35. So it's not the best, but it's still like a good compromise, not a good compromise, but some sort of a compromise. Now that we have the segmented cellular tumor volume, I wanted to see if we can actually detect recurring disease using that. So in my data set, I had 192 cases in which there was residual tumor or recurring glioblastoma, and 51 cases were negative, no residual disease, no recurring things, double-checked by 3 people. And so by applying, a naive threshold on the segmented volume of cellular tumor, everything above the threshold was positive, everything below the threshold was negative. And by varying the threshold from 0 to 50 milliliters of tumor, you can plot this thing here which is the receiving operating characteristic, and you can compute the area under the curve to see the performance of the system to detect something. And the area under the curve was actually 0.84, which is good. I mean, the AUC for conventional radiologists is between 90 and 95, depending on the literature. And interestingly, if you substitute RSI for conventional ADC, you lower to 0.82. It's not a small difference. And the reason is that most of the recurring disease are not infiltrative disease. It's more like enhancing glioblastoma. And you don't really need RSI to actually segment enhancing cellular tumor. So we were quite happy about that. And on the external data set, we got an AUC even a little bit higher, 0.91, which was really nice for us. Now, regarding survival analysis, we used this volume of segmented cellular tumor and see if we could predict patient survival with that. On a subset of 94 patients from the 178 patients, we had survival information, how long between the diagnostic and the death, how much day occurred between the death of the patient and the diagnostic. And all of these patients had an MRI scan in the 90-day period following the surgery. And so we compared the volume of segmented cellular tumor against standard regressors such as age, sex, and GDR status, which is a binary marker. It's 1 if we remove completely the tumor during surgery based on the postoperative MRI, or 0 if there's still some residual tumor. We call that partial resection. GDR is gross total resection. And so what we found using a Cox multivariate analysis is that the volume of cellular tumors segmented predicted survival independently of age, sex, and GDR status with very good p-values. Overall survival is just the survival of the patient, and progression-free survival is the time between the diagnostic and the date of the first recurrence on imaging. Another thing we tested is that cellular tumor volume predicts survival independently of this biomarker I told you before, which is the volume of residual enhancement in the postoperative MRI. Again, for both overall survival and progression-free survival. For a subset of these patients, 67 patients, 67, we had the MGMT methylation status, and we found that the volume of cellular tumor predict survival independently of MGMT, age, sex, and GDR status, all these 5 regressors together. So it's nice to see that not only you can predict survival with that, but it gives information independently of conventional biomarker, because these 2 are conventional biomarker used in the clinic, actually. Another interesting thing we found is that non-enhancing cellular tumor is independent from enhancing cellular tumor in terms of prediction. So it's important to separate the 2. And also, non-enhancing cellular tumor predicts survival, but the volume of the flare signal hyperintensity that is illustrated in green here, comprising both edema and infiltrative disease, does not predict survival. So it's really important for this method to be accurate to separate infiltrative disease from edema using our model and using RSI. We had 3 different data sets to test this survival analysis. One was postoperative, the Lumiere data set, in which cellular tumor predicted survival independently of age, sex, and GDR status. And we also tried the model, although the model was trained on postoperative data, we used it on pre-op data. So 2 data sets available online, a UPenn and UCSF data set, more than 1,000 patients combined. And we found that the volume of segmented cellular tumor predicted survival independently of age, sex, and GDR status for either total cellular tumor, so enhancing and non-enhancing, or individual enhancing or non-enhancing cellular tumor. So this was really encouraging. Because it solved the problem of giving preoperative survival prediction. This is just examples of how you can stratify survival using the volume of segmented tumor on the pre-op. So here I showed you Kaplan-Meier curve. The curve is stratified using the median tumor, the median volume of tumor, and everything that is above versus everything that is below. And I show you the odd ratio here. And I also show you the odd ratio if you compare the percentile 1 to 25 versus percentile 75 to 100 in terms of volume. If you compare that together, the odd ratio goes as high as 2.3 for non-enhancing cellular tumor. A odd ratio of 2.3 means that on a given period, you have 2.3 times, you're 2.3 times more likely to die in a given period if you have a huge volume of non-enhancing cellular tumor compared to if you have like a small volume. So although we had very good results, there's still a limitation in this study, and these limitations prevent the work to be implemented right now in a clinical workflow. I think the first one is the last one here, histology validation, because in order to convince a neurosurgeon to operate and to remove this part of tumor that we are segmenting, you need to compare against the gold standard, and gold standard is really histology at that point. So we'll need to validate that with histology. And the other thing is that we had no clinical information included as input in the model. So we only used different MR sequences, and the model segmented the tumor by itself. But as we will see, it's important to include sometimes clinical information in order to take into account some specific facts. And also only limited validation, especially for post-operative data, because at that time in 2022, there were not a lot of post-operative data set available online, but this has changed a little bit today. So everything I presented was the work I did during my fellowship at UCSD, and then I just import all this powerful technology to Quebec City at Université Laval and founded my own lab. And I'm going to show you now some ongoing projects which are trying to fix the limitation of this nice study. So first one is histology validation. The problem is that it's really hard to find a data set which has both MRI data and histology. And most of the data set available, such as the UPenn and the University of Wisconsin data set, they don't acquire multishell diffusion. They don't acquire RSI. They just acquire standard diffusion, and sometimes it's just conventional MRI imaging. So I would be able only to compare the down-tuned version of my AI model and not the full powerful version. I still want to do that, but I think it's limited. One thing about the University of Wisconsin, though, is that because it's post-mortem, so after the patient died, they freeze the brain and they slice it. So for each MR voxel, you actually have the histology, and you can compare each voxel with the histology. So you can think about having a validation in terms of math. But because both of them don't have RSI, I just decided to get my own data set at CERVO. So we have this nice Siemens 3 Tesla Prisma scanner. Advantage of Prisma is that we have stronger diffusion gradient compared to clinical scanner. So we can go up to B 8,000. At UCSD, I was limited to B 4,000. And we have this nice neural navigation system allowing to map every point on the image three-dimensionally in the operating room. And we have two neurosurgeons that will actually, from a preoperative MRI, they will take biopsy of different regions of the brain during the surgery, and we'll be able to compute the sensitivity and the specificity of our cellular tumor map and quantify the accuracy. So my graduate student, Philippe Dion, is doing his PhD on this project, and we are, all the ethics protocol are accepted, and we're starting to collect patient, probably like in the following weeks. In the meantime, we've done some testing using PVP phantom. PVP is a substance, like a viscous substance, and by varying the concentration, we wanted to make sure that by performing our RSI measurement or diffusion measurement, at high, ultra high b-value was stable in the model. And so here what you see is the RSI cellularity as a function of the PVP concentration, and you see this nice linear relation. And on the opposite, the free water compartment of the RSI, which is another compartment, is linearly decreasing with an increase in PVP, which is both expected. And we did some intraday and interday cross-validation to make sure that everything was stable. Another project that we have in our lab is to actually do some diffusion MRI modeling and optimization. So I'm a physicist by training, and I did a lot of modeling, MR modeling in the past. And one thing I wanted to look at is, this bright RSI signal that comes from this circle harmonic decomposition. How can we optimize this bright signal and make it even brighter, and to improve the conspicuity between tumor and healthy brain? And in order to do that, we need to do some more advanced modeling. So one of my graduate students, Jeremy, developed this Monte Carlo tool in which he was putting some cell with different size and cell density, and also some different size for the nucleus versus the cytoplasm ratio. So cell density and nuclear to cytoplasm ratio are two different markers that the pathologist will use on a biopsy sample to identify if the tissue has tumor or not. So we know that the tumor cells have a large nucleus compared to healthy cells, and they are more packed, so the cell density is much higher in tumor compared to healthy brain. And so by varying these two parameters, you can run Monte Carlo simulation with different strength of the diffusion gradient, and you get this nice curve. And in order to get an idea of the conspicuity, you can think of computing the slope of this curve, because you can imagine that healthy brain will be here versus tumor will be here, and the slope gives you the difference in signal that you get from healthy brain to brain tumor, and this gives you a sort of conspicuity between the two tissue type. And you see that by increasing the b-value from 4,000 to 8,000, you increase the slope by 10% for cell density, and you increase the slope by 47% for N/C ratio. So we are encouraged that cranking the diffusion gradient strength in our scanner at CERVO will allow us to get better conspicuity with RSI. You can also compute other statistics, such as the Cohen information coefficient. And so one thing we did here is that we compared RSI with conventional ADC, which is the aberrant diffusion coefficient. And the reason is that one could say that, of course, if you put stronger gradient, RSI would be better, but it would also be better if you do it for ADC, right? But this analysis here shows that it's not really the case. So if you compare at B8000, the Cohen's coefficient is twice the amount for RSI compared to ADC. And for the N/C ratio at B8000, it's more than 5 times the amount. So the increasing conspicuity is much more important for RSI compared to conventional imaging. So this is a kind of nice slide representing what in the future I would really like to do. I would like a more realistic model. Instead of modeling, idealized sphere, I would really like to take input from histology and generate a 3-dimensional, geometric structure representing tumor tissue, and run Monte Carlo simulation in this structure to get a more realistic model. One of my summer students 2 years ago did this analysis from 2-dimensional H&E histology. She was able to segment the actual nucleus of the tumor, but the cell boundaries were hard to segment. But just with the nucleus, she was able to show that you can get some realistic diffusion MRI curve from Monte Carlo simulation. But I would really like to improve that in the future to get a more realistic model. Another project I want to talk about is the project of my graduate student, Abel Badawi. So I told you before that when the code is actually segmenting the tumor, is not using clinical information, just MRI inputs. And same thing when we apply this threshold here to distinguish recurring disease from post-treatment changes, we're just applying naively a threshold by increasing the value of this threshold. But when, as radiologists, we read clinical cases and we do tumor board, we rely heavily on clinical information, especially MGMT. Because it influences the pseudo-progression probability. In fact, if you have an MGMT negative cases, you only have 10% chance of getting pseudo-progression. But if it's MGMT positive, then it's more than 50% chance. So if you have a case and you hesitate between pseudo-progression and recurring disease, but the case is MGMT negative, then it's very hard to get to the progression, or very unlikely to get to the progression on an MGMT negative cases. Same thing for chemotherapy and radiotherapy. It can give rise to radiation necrosis, as we saw before, and other post-treatment changes, which looks very similar to recurring disease. But if the patient never received chemotherapy or radiotherapy, we're not going to call radiation necrosis or post-treatment changes. We're going to call recurring disease if we see something suspicious. But the code doesn't use that, so it would be nice to include this information. And the timing is really important too, because chemotherapy and radiotherapy will induce changes in the 3 to 6 months following the treatment. But if it's been 5 years, it's not the same story. So my graduate student designed this decision model based on an extremely randomized forest model, in which you can include not only the imaging volume, but the MGMT profile, as well as chemotherapy and radiotherapy information. And we had this information for a subset of the patient in the UCSD cases. We had 137 cases. And what you see here is that this is the conventional method of using only the cellular tumor volume. You get an AUC of 0.837. And if you start including clinical information, chemotherapy, radiotherapy, or MGMT, you boost the AUC. And if you combine all three, you get the highest AUC, and it's a difference of 0.02, but 0.02 on a data set of 137 cases with a threshold of 1 milliliter of tumor. It's the equivalent of between 1 and 2 cases that you would detect here and that you would have missed here. So for these 2 patients, it's totally game-changing, right? Because you treat them instead of missing the diagnosis. So we were pretty excited by this data, and we have a manuscript under revision right now regarding this data. The last project I want to discuss is a little bit different, but I still want to talk to you about it, is the oxygenation mapping with MRI in brain tumor. So oxygenation level is important in tumor imaging because it's a predictor of response to radiotherapy. And the reason for that is that in neurobiology models, the amount of free radical that you can produce with radiotherapy will depend on the oxygen concentration. So you can actually try to predict radiotherapy response with tumor oxygenation. And the other thing is that for glioblastoma, it's a measure of metabolism, because glioblastoma has this oxidative metabolism pattern, but they have the capability to switch their metabolism to anaerobic metabolism, so non-oxidative metabolism. And when they do that, they are not responding anymore to chemotherapy, radiotherapy, and more, they are not responding to anti-angiogenic agents. So if we could use oxygenation mapping to predict which patient are going to respond, we could target the treatment for the specific patient. Now, measuring oxygenation on the human head, on the human brain, it's difficult. You can use oxygen 15, but you need the cyclotron next to the imaging room, because the half-life of oxygen 15 is 2 minutes. But nowadays, there are MRI techniques that are capable of doing that. One of them is called Cuboid. It was invented like 15 years ago. But in the next 5 years, it has improved significantly because of correction for magnetic susceptibility, and with the AI innovation in terms of smoothing and clustering in terms of inverse problem. Because the thing is, you measure something, and with an analytical model relating the oxygen content in the vessel to the MR signal that you're measuring, you invert this analytical model, and you recover these parameters. And one of the questions I wanted to ask is, there is an assumption in the model about the vessel geometry on the healthy brain, but is it going to work also on brain tumors? So I wanted to do simulation and see what's the effect of breaking this assumption on the recovered OEF. So I went back to an old model that I developed during my PhD, which uses two-photon microscopy to actually measure the vessel geometry. And after that, you can populate these vessels with some oxygen content. And because the deoxyhemoglobin is paramagnetic, you can compute some magnetic field perturbation and run Monte Carlo simulation there. And the bold signal is actually sensitive to these shifts in susceptibility. And cuboid is basically the same instead that you're using either asymmetric spin echo or multiple T gradient echo. So I used this model to actually simulate cuboid, and I started with my mouse angiogram, healthy brain on mouse angiogram, and a surprising result that if I compare the simulated OEF to my recovered OEF, there's an underestimation of almost 50%. So each line is a different model. This is a symmetric spin echo, and these two, green and red, are multiple TE gradient echo. And I went back to the literature, and experimental measurement on mouse show lower OEF compared to humans. It should be around 35 to 40% for humans, but in mouse, it's between 20 and 25%. And we don't believe it's real. One of the hypotheses is that the model was derived using vessel geometry on humans, but on mouse, it's not the same. It's much smaller vessel. So one thing I did is that I switched my vessel to straight cylinders, and I started increasing the diameter. And as you see here, I could remove this bias by doing that. So it suggests that because of smaller vessel, mouse will have, or this technique will give underestimated OEF changes in mouse brain. So next step, I got some van model like that, but measured on humans from one of my friend at Stanford, and I'm going to run Monte Carlo simulation to see if I can resolve this kind of paradox by running a simulation on human vans. And of course, this is kind of a step back because it's not working at the beginning, but the goal is actually to quantify the accuracy in brain tumor to use it in brain tumor, because what we want is oxygenation in brain tumor and in the surrounding tissue. So in summary, I think I convinced you that multishell diffusion MRI is powerful, and that when we combine that with deep learning segmentation, we can actually cool stuff. And powerful stuff, including separating infiltrative disease from edema in glioblastoma MRI. We can also distinguish residual disease from post-treatment changes in post-operative MRI, and we can actually predict survival independently of traditional biomarkers. And more than that, so cellular tumor maps are interpretable by clinician. We can actually project the map on the neuronavigation system, and the neurosurgeon can see it live during the surgery. But however, we need some more validation with biopsy before being deployed on a clinical workflow, and we need more optimization and modeling in that case in order to optimize the technique. So on that, I want to thank my graduate student and my summer student for performing the work I showed you today, and thank you everyone for your attention. I'm going to be happy to answer any question if you have.
Excellent. I'll change the camera here. Fantastic. Well, thank you so much, Louis. Very interesting talk. We have time for questions. I did want to point out one thing I forgot to mention when I introduced you, going back to our early days. As we can tell from today's talk, Dr. Gagnon is a very intelligent, ambitious person. When I met Louis, it was in May of 2006, and he spoke English as well as I speak French, which is not very well. By the end of the summer, by August, he was completely fluent in English. It was remarkable how fast he learned the language, and I think that applies to the rest of your abilities as well. So anyway, we have time for questions. Take them from the room. Anyone online, if you want to ask a question, feel free to unmute and ask it, or type it into the chat and I'll read it. We have a question in the room, though. Right, you want to come up or? Sure.
Thank you so much for the talk. It was very interesting. I was wondering, you point out susceptibility briefly in the context of QBall, but here there was a study that used susceptibility to basically characterize iron metabolism in the edema region, and then they associated abnormal metabolism of iron in the edema with infiltration of tumor in the edema region. So maybe think about the use of susceptibility in this context and maybe new techniques that do both diffusion MRI and QSM at the same time.
Yeah, I think you're totally right. I think that's why we want to do it on some control environment first, because everything will be disturbed in the tumor, right? The vasculature is not the same, as you said, maybe iron content or everything like magnetic is not really the same as healthy brain. So it can create some artifact and susceptibility shift that we're not accounting for in this model. So it's not guaranteed that the model will give accurate oxygenation in the tumor. So one thing I thought, though, is that even if we don't get good oxygenation in the tumor, maybe in the surrounding healthy brain, we can get decent estimate. And so radiotherapy is also important in the surrounding tissue, because that's where the recurring disease will occur, right? So it's possible that we won't be able to measure oxygenation in the actual tumor, but if we can get an oxygenation map, in the surrounding tissue, that might be an alternative that would be clinically useful.
Very interesting. Thank you so much.
Thanks.
Okay. Anyone else?
I have a question.
Yes, Christian. I think we can hear you if you.
Can you hear me okay?
Yes.
Thanks for the great talk. I'm just curious about your deep learning model input, the contrast enhanced image. Are you just inputting the images like a single image post contrast, or are you inputting like the dynamic time series?
So for the T1 post contrast, it's only one three-dimensional image. So basically, we acquire the image like 5 minutes after contrast administration. For the perfusion, what we are inputting is the post-process time series. So we have this time series. We use what we call the DSC toolbox in MATLAB, which will compute, from the peak and the area under the curve of the dynamic series. CBV is the area under the curve, and the time to peak is the actual CBF. So we use the CBV to reduce noise, and we input the CBV map to the model. So at the end, it's only one volumetric image, but it's derived from this time series, which lasts like 30 seconds, basically.
Great, thanks.
Super. Anyone online?
Hi, maybe I have a couple of questions, Peter.
Please
Can you hear
go
me
ahead.
okay? Yeah.
Yep.
Thank you, Louis, for a great presentation. I'm wondering if you can comment on a couple of things. One is, you mentioned some of your research is limited by the availability of restricted spectrum imaging on the one hand. So I'd like you to comment on why that is. And second, on the feasibility of QBOLD/OEF measurements in patients. Do you see QBOLD kind of acting as a solid research tool, or do you see it actually translating to the clinic?
So let me start with QBOLD, and we can come back to RSI after that. I think QBOLD to measure baseline OEF, I think it's applicable to patient, because honestly, it's like a 5 to 6 minute acquisition, and the patient doesn't need to do anything. It's not like doing functional MRI in which you try to measure a change in OEF during a pattern of activation or anything like that. This I wouldn't do it. Although they do fMRI in pre-op patient to identify some region and try to avoid these regions during the surgery. I think here the baseline OEF QBOLD is applicable in patient. It is just an extra 5 minutes. And the first part of your question regarding RSI, so there's two reasons why it's not widely used. Is that In our scanner at CERVO, it's a 5 to 6 minute sequence because we have strong diffusion gradient. If you go on clinical scanner, it's a little bit longer. It can be like between 7 and 8 minutes, and sometimes they don't want to get this extra 7 to 8 minutes. So that's the first reason. Second reason is that technically RSI is patent protected because my advisor at UCSD patented it. So you cannot just get if you want to get the package with the analysis tool, you need to pay. But you can decide to set your scanner with different measurement, with different b-values, and get your own code to analyze it. It's not very difficult, and I think there's some GitHub on internet on analysis package. But I think the fact that it was patent protected and it was licensed to GE initially has limited maybe the widely used thing. But again, if you can prove with biopsy that what you get is real, then I think even if it's patent protected, people will buy the sequence, right? So it's like buying ASL. You need to pay some money, but because we know it's useful, people will buy it. So I think with more validation, it's going to be it can be rapidly available, more widely.
It's a really interesting comment you make about the impact of the patent on the availability, right? Because the initial thought behind patents is that it actually makes ideas more available, not less available, because they're protected and they help the inventor benefit while still making the idea available. Listen, I don't want to hog the other time if there are other questions, but I think that's kind of an interesting idea. But is it the pulse sequence that's patented, or is it the analysis technique?
I think it's kind of a package.
Okay.
Both packages, everything is packaged, but I mean, it's
so ultimately,
in terms of research, it's easy to implement. So of course, if you want to use it and sell it,
but
it's different. But if you want to use it for your research, it's
clinical translation will really depend on the vendors making it available, because that would be sort of Health Canada approved, and so that's really quite interesting as a comment. So ultimately, this validation effort that you're taking on and that others are taking on is going to be super important to help either convince or not convince the vendors to license the technology, right? Because if it's only you're saying it's currently available as an add-on on GE platforms, but not on other platforms.
Not yet. I don't think they have licensing agreement. But I'm pretty sure that if we can get validation, other platform will ask for licensing, and I know my advisor would be it's Ender's Day, right? He will be really happy to deploy that, to make it available to everybody. It's not an issue.
Very interesting. Very interesting work. Thank you for your presentation today.
Thanks.
Good. All right. Well, we're at the hour. If there's a last minute question. Otherwise, I'd like to thank Dr. Gagnon once again for a very interesting presentation and for speaking to us today. Thank you, everyone, for attending. Have a great rest of your Friday and a good weekend. Bye.
Thank you so much. Bye, Pete.
See you later.